thank you for being here to the KHS Research Seminar. I'm Dr. Haber. I'm going to moderate this afternoon. We have our speaker today, Dr. Mang. He's going to be talking to you about calling all kinesiologists. Neurorehabilitation Needs You. Cam will be speaking for about 45 minutes. Once he's done, we'll have about another 10 to 15 minutes for questions. And unfortunately, those that are joining us by live stream, we don't really have a great option for connecting. However, if you have questions for Cam following the presentation, you can probably contact him directly through email if you have any questions. So I'm going to turn it over to Cam for his presentation.
Great, thanks, Lorena. Thanks for the introduction. Thanks for everyone who's here, in person and virtually. So before we start, I did want to begin with Territorial Acknowledgement for the University of Regina, situated on the territories of the Ne'iyuwak, the Nation of Dakota, Lakota, and the homeland of the Chip Nation. The University of Regina, Treaty 4 land, and Treaty 6. I put up this picture, I've done it in prior acknowledgements, because embarrassingly, when I moved to Regina, the first 18 months, I drive past the art gallery and look at that and think, well, that's a nice line of poetry. I love the outdoors too. And I had no idea that in fact it's a statement, or it's a line taken from the understanding of how Indigenous people's understanding of the treaties and the sharing of land for the rest of the time. And so I kind of try to remind myself now when I drive by there that ignorance is not necessarily bliss. And then also just including that meme in the middle there because I came across it the other day on CBC. And I made me reflect. I spoke last week at the biology seminar and I chose not to provide an acknowledgement. But I think I decided to provide today just with the recognition that these acknowledgements are really the least that we can do. So on to presentation. Calling all kinesiologists, neurorehabilitation needs you. Like I said, that's my mood base. It's not meant to be. The presentation today is really based on a perspective review paper that I recently published. And the purpose of that paper was to initiate, and the purpose of this presentation really, is to initiate some conversation on whether long-term motor rehabilitation for adults with chronic neurological conditions might be advanced through greater involvement of kinesiologists. So a conversation might happen after the presentation, or maybe as you all go off and share your lives. The presentation is broken into 4 main parts. I'm going to start by talking about neurological conditions in general, just to give a little bit of background for everyone. Talk about the concept of motor rehabilitation, particularly in the chronic stage of recovery, so that's referring to 6 months or a year after somebody has had the onset of a neurological condition. Then we'll talk a bit about kinesiologists. I know that people know who kinesiologists are, but sometimes a little refresher doesn't hurt. And some recommendations that we came up with within the paper. So beginning then with neurological conditions. So back in 2014, the government of Canada published this report. It was called Mapping Connections. And it was created to describe the prevalence, incidence, and impact of neurological conditions on Canadians. So the report relied heavily on a survey that was done in 2011-2012. And according to the report, in 2011, there was about 3.6 million Canadians in the community and 170,000 in long-term care living with the effects of neurological conditions. So I think in 2011, our population was about 34 million. That means if we're talking about more than 10% of the Canadian population, the population is higher now. In terms of what I'm talking about when I talk about a neurological condition, obviously this is quite a broad term. But what I'm talking about broadly is any disease, disorder, or injury that affects the function of the central, so think brain, spinal cord, or peripheral, think everything else, nervous system. And neurological conditions can be the result of structural changes in the nervous system, like a stroke or a spinal cord injury, biochemical changes, think of like Parkinson's and the dopamine system, or electrical changes, think of something like epilepsy in the nervous system. And of course, because this is such a broad term, the causes of neurological conditions depend very much on what condition we're talking about, and are quite variable, but keep in mind that even within a neurological condition, the causes tend to vary a lot. They're complex given that the nervous system is essentially our command center of the body, you can imagine that the symptoms that people experience if they have a neurological condition vary markedly. And that's not just across neurological conditions, but even within a condition, depending on the location of the issue or the degree of severity. So the Mapping Connections report that I mentioned, it considered 18 neurological conditions. And they range from severe to mild conditions, from progressive to non-progressive conditions. And as I said, the symptoms vary, but one of the most common symptoms or challenges that people face are challenges with movement. So of those 18 conditions that were reported on, 12 of them were found to have a prevalence of higher than 20% of impairments in mobility. And that's talking about kind of getting from one place to another. A related study called the LINK study done around the same time. So LINK is the everyday experience of living and managing a neurological condition study, reported that more than 40% of Canadians with neurological conditions experience also upper extremity challenges with movement. So kind of drawing some inferences from there, then you could say that in around 2011, 2012, there were about 650,000 Canadians living with mobility challenges and 1.5 million Canadians with upper extremity impairments due to neurological conditions. Okay, so how do we end up with so many people in this situation? Well, the way that our system works is that if you look on this side over here, so I'm referring to acute conditions. So somebody's had a stroke, an emergent condition. So you head to the hospital essentially. And you make your way through in and outpatient rehabilitation, and eventually you're discharged to the community. And then you've got this other group of people who have these sort of non-emergent conditions, let's say MS or Parkinson's. You get a diagnosis. You maybe get a little bit of outpatient rehabilitation, and again, you're sent off to the community to try to manage things on your own. All right, and when you think back to that prior slide the last slide that I had showing that prevalence of movement challenges among people with neurological conditions, that's not challenges right after the onset of the condition. That's challenges that they are living with. So when they get to the community, these challenges are persisting. All right, so as a result, what you have as we work our way through this system is just a buildup of people in the community living with these effects. And we can imagine that as like the Mapping Connections report, we're halfway through their projection period, and over the 20 years they expected these numbers to just go up and up and up, as you can imagine. That's partly related to our aging population, and the link between some neurological conditions and the aging process, and partly because of just population growth in Canada. So we're talking some pretty big numbers if you can read those over here in terms of function as a result of neurological conditions in Canada. So with that background then, I just want to talk a little bit about rehabilitation, particularly in that chronic stage when people are out living in the community. So it's always good to start by defining a term. So there's a definition of motor rehabilitation up on the slide there. And some of the key terms that I want you to look at are interdisciplinary. So that's to say we're talking about rehabilitation of movement, but there's not just one discipline that does that. It's multiple disciplines working together. Another key word is physical function. All right, so rehabilitation is really about improving physical function. And we're going to come back to it a little bit, but that's related to, but not the same as fitness. All right, so function and fitness are a bit different. And rehab is really all about function. And so this chart here, it shows kind of the main healthcare providers that are involved or typically thought of when we think of motor rehabilitation for people with neurological conditions. So a physiatrist is like a specialized physician, PT, OT, physical therapist, occupational therapist. And I've kind of got a breakdown of how they contribute there. And of course there are other people involved. I'd never forget the rec therapists, the nurses, the psychologists. But when we think of motor rehabilitation, this is sort of our main team. And when we think about this team and when they're involved, we usually think about that acute or subacute stage, so right after the onset of the condition, maybe 6 months out, maybe a year out if you're lucky.
all right? And the reason that we think about that time is because there is evidence that there's sort of a critical window of recovery, that providing that rehabilitation in that early time after the onset of the condition is quite important. But it's important to recognize that that window doesn't completely close. And I've got a little guy here. It just gets a little bit harder to access as you get out of those and past that sort of 6-month period. And so we do actually have lots of evidence now that recovery can continue in these later stages. And so more related to this kind of critical window idea is the question, and this has been raised in the literature, is to whether it is a little bit of a self-fulfilling prophecy. Okay, and so that's the idea that if you look at people's contact with our rehabilitation professionals after the onset of a neurological condition, they tend to have pretty frequent contact in those early days, so in and outpatient rehab, daily to weekly contact maybe, and then we gradually pull it back and back and back, and if they're years out from their injury, they might see a specialist once a year, maybe twice a year. All right, so the question becomes, do people plateau and stop getting better because the window has closed, or do people plateau and stop getting better because we've stopped giving them services? All right, so just something to keep in mind. And one person who's really kind of tackled this is a guy named Bob Teasel. He's out at Western. He's a stroke physician and a researcher. And about 10 years ago, he started a review because he was curious. We don't provide resources to people who are in the chronic stage of recovery after stroke. Should we be? It was kind of his question. So he started this review, and as he writes it, he was shocked at the number of papers that he found that involved chronic stroke rehabilitation. So he found 339 randomized controls trials, and 256 of them were related to motor recovery. And some key findings that he found were that most of the studies indicated that walking function could be improved by various interventions, or upper extremity function could be improved by various interventions, even though people were in this chronic stage. So this is a case of where our evidence, for one reason or another, is not making it into practice in terms of the resources and services that we provide people. So with stroke as an example, because it's one of the most heavily researched neurological conditions out there, it seems that there is good reason to provide further motor rehabilitation in those chronic stages of recovery. So I'm talking after 6 months. And that rehabilitation, it might take the form of something that we would call like task-oriented exercise, where you're working on those specific functions, as I mentioned, physical functions. But it may also take the form of more general exercise. And although those two things, rehabilitation and exercise, are often considered distinct or separate from one another in terms of their goals, I think that line gets a little bit blurred when we're talking about chronic health conditions, because now we have situations in which improvements in fitness can also give us improvements in function. All right, and so I think it's just important to keep in mind then, just like I said, when we're talking about motor rehabilitation, we can, in the case of chronic neurological conditions, be also talking about exercise. So the way things are set up right now, when people get out into the community and they have these chronic neurological conditions, these continued movement challenges, there's a lot of barriers to them continuing on this path of recovery. And of course, this would be an optimal path. Not everybody, given resources, would be able to fully recover. Very few, in fact, but people could continue to make gains. And unfortunately, we have a whole bunch of barriers to being able to, engage with those things. So first thing that's often cited in the literature is therapist availability. When you're out in the community, you can't find a therapist who specializes in this to provide you with a service. Another is location. You may not live in a major city center. Another is cost of specialized therapy. And then related to that are insurance limitations. So you only have so much insurance coverage before it runs out. All right, and as a result of all those barriers, instead of people continually getting better, when they get out into the community, they end up in this sort of cycle where they have a functional movement impairment. They end up doing less physical activity as a result. their fitness and health generally goes down, then their functional capacity goes down even further, and they just kind of keep on spiraling. So, enter the kinesiologist. All right, what is kinesiology? It's broadly defined as, we all know, the scientific study of human movement. So we're talking biophysical, sociocultural, psychological, neuromotor aspects of movement. I probably forgot something. And to my understanding, kinesiology grew out of the field of physical education, not necessarily phys ed as in terms of a teacher, but as an academic discipline. Okay, so it was initially thought of as a scientific discipline, academic discipline, but as kinesiology and physical education programs started graduating people, a lot of people went out into professional type positions working in the practical world. And so eventually the idea of the profession of kinesiology was recognized. And so kinesiology practice now, this is one definition, borrowed from the College of Ontario Kinesiologists, the assessment of human movement and performance and its rehabilitation and management to maintain, rehabilitate, or enhance movement performance. And now, I'd say it's relatively common for an individual in Canada who graduates with a degree focused on kinesiology to call themselves a kinesiologist. And kinesiologists are human movement specialists, of course. But because of that broad scope that I provided you with in that prior slide, we run into a fair bit of confusion oftentimes. All right, so the case is that people start to ask, well, what does a kinesiologist do and what does a physical therapist do? Or what does an occupational therapist do and what does a kinesiologist do? And I think it is important for us to try to define and understand this a little bit better as we try to move out into the world and really make carve out a place for ourselves. So just key distinction, it's important to recognize that kinesiologists generally have undergraduate training. Generally, these are generalizations, work with people with stable health conditions. They do not diagnose new conditions. Big generalization, they often work in community centers. Another generalization, often have a lower cost of services relative to a therapist. Physical therapists have graduate training now. They didn't used to, but they do now. They have more expertise and more training, particularly in pathology, manual techniques, and modalities. They commonly work in clinics and hospitals, and their services are often covered by insurance to some extent with limitations, as we discussed. So physical therapy, of course, from when it was initially dreamed up, was always a practical profession. So just revisiting this slide here, we have this growing buildup of people. We know that providing further services can help people to get, further gains, but we have all these barriers to it, and a lot of the time people do not. All right? And so we have our typical rehabilitation team, our physiatrists, PTs, OTs, but people can't really access their services out in this later stage. I'd also like to mention or kind of remind us about that blurred line between exercise and motor rehabilitation when we think about chronic neurological conditions. So there's ample evidence of many benefits of participating in exercise for people with chronic health conditions, including neurological conditions. And we even have this exercise as medicine movement here, which promotes the prescription of exercise for people with chronic health conditions. And I think it's fairly well accepted that, who better to deliver that type of service than a kinesiologist. But when it comes to neurological conditions, historically, kinesiologists are not really involved. So here again is our typical motor rehabilitation team for people with neurological conditions. This is, we think often of in- and outpatient motor rehabilitation. And so here's a suggestion that we make in the paper. And I should have said this before. The paper is authored by me and colleague Sue Peters, who is a physical therapist. So this isn't just coming from kinesiologists. This is also coming from at least one physical therapist. So our suggestion then is that when we get out into that chronic stage of motor rehabilitation, if we want to be able to continue to provide it, let's carve out another role. Let's carve out a piece of this pie, all right? Because we know we're getting, minimal contact with these professionals here. So let's add in a kinesiologist who can come in here and start to potentially provide more frequent contact and help us to break down some of these barriers. So the barriers that we can break down, of course, are we've got this buildup of people. We don't have enough therapists. Let's add some kinesiologists into the mix. We think about, that also relates to location of services. We can think about the affordability factor when we think about the fact that when insurance coverage for therapy runs out, perhaps you can then access a more affordable kinesiologist. So, like my little karate guy there, try to break down barriers through the involvement of kinesiologists. And so, given the general presence of kinesiologists in the community, an ideal medium through which KINS could help is through delivery of community exercise programs. So there are some programs out there that exist. There's the TIME program developed by Nancy Salbach out at the U of T. There's the FAME program developed by Janice Eng at UBC. These are programs both developed by physical therapists, practitioners, and researchers. TIME and FAME, both of those are programs that focus on balance and gait, and both of them involve, say that to lead the programs, you just have to be trained by their staff, short training weekend, and you have to be certified as a personal trainer or a fitness instructor. So they're requiring just a 25 to 30-hour certification. Some challenges that have been run into with TIME and FAME relate to program fidelity. So talking about, is the program being delivered the way that it's meant to be delivered? Are people getting the rehabilitation that they're meant to be getting through these programs? And sometimes that is not the case. Another challenge that's faced is that there have been reports from people with disability and people with neurological conditions that there is a perceived lack of fitness instructor expertise for working with them. And we're talking about these people with 25 to 30-hour certifications. Then another consideration is that these are programs, again, focused on balance and gait, generally for our ambulatory population. Okay, so that's people who are walking. So they're appropriate for a very specific subset of people. We have all these other people who have potentially more severe or even moderate symptoms related to neurological conditions that would not be able to access these. So I would suggest then that incorporating kinesiologists more deliberately into delivery of these types of programs could help us to overcome some of these challenges. So a 4-year degree relative to a 30-hour certification, I think could go a long way in terms of ensuring program fidelity, ensuring appropriate expertise, and then also being able to, go beyond just standardized programming to individualized programs towards more than just a very specific subset of people. So moving into our last section here, thinking about some recommendations that we could make in terms of how do we put all this together and start to go forward. The first recommendation relates loosely, or not so loosely, to the professional regulation of KINS. That is the lack of professional regulation of KINS. So kinesiologists generally have associations. This is great. These are professional associations that they do things like provide access to insurance for kinesiologists. They advocate for the profession. And you can see here I've got 9 out of the 10 provinces listed, and that's how it was for a long time. And very recently, this one down in the bottom, Saskatchewan joined. So what does the Canadian Kinesiology Alliance and all of these professional associations do? Like I said, they help to provide insurance, professional liability insurance for kinesiologists. They do some work towards thinking about standard competencies. And right now they have about 4,500 members. There's probably a lot more KINs out there who are not members. Some things that they're working towards are creating an entry to profession exam, creating a research and academia committee, which, full disclosure, I'm a part of, strategic plans and developing relationships with other organizations, which I think will be very important. But still, even with those associations, without regulatory bodies that protect the public, we are going to be limited in terms of kinesiologists getting involved in neurorehabilitation. In trying to publish this review paper, that was the biggest pushback from reviewers, was that kinesiologists are not regulated. How can we use them with this potentially vulnerable population? So what that involves then in terms of regulation typically is like some sort of licensing and entry to practice exam. You can see the Canadian Kinesiology Alliance is working towards that. Consideration of rules and guidelines for the profession, mechanisms to investigate complaints, and a public registry of practicing kins. And so there is precedent for this in Ontario. There's the College of Kinesiologists of Ontario, but that's fairly unique. We don't see that in too many other places, even though many of these provincial associations have been working towards it for a long time. So at this point, because widespread regulation is unlikely to happen overnight, and we have this growing accumulation of people, we made the following recommendation that kins in a neurorehabilitation team should have an undergraduate degree in kinesiology from an accredited institution, that they should still be registered with one of those local professional associations and have liability insurance, and that ideally they should have gained some additional experience under supervision, excuse the typo, of another rehab professional. And our hope is that, by following this kind of a recommendation, we could have a safe initial integration of kins into the neurorehab team, and, by having that insurance, not place any additional liability onto other healthcare providers. Because that's another concern that often comes up for like a physio or a doctor, is that are they going to be liable if they refer someone to a kin? Another consideration is that we could potentially do more to increase kinesiologist training in this particular field. So it was actually suggested through the review process of the paper that one approach might be to establish neurological motor rehabilitation as a subfield within kinesiology. Obviously that would take a lot of work between educational institutions along with your associations and your professionals. Something that would be more actionable would be the development of some sort of certification or specialization in chronic neurological motor rehabilitation for kins. There are specializations and certifications in neurorehab out there, but generally they target physical therapists and occupational therapists. And so if we had something that was targeted to the kin scope of practice, we think it could go a long way in terms of carving out a specific role for kinesiologists and not overlapping with those other professionals. Our next consideration relates to models of care in neurorehabilitation. And as we mentioned, we have that sort of like evidence to practice gap where things aren't happening and we don't have the resources for people. If you use stroke as an example again, you can imagine somebody heading to the hospital, stabilizing, going into inpatient rehab, outpatient rehab, and then going out into the community. And yes, there are some resources and some things for people to access out here, but generally there's nothing all that formal. So we would suggest that there's a great need for more formalized healthcare to community partnerships, and that kinesiologists could be deliberately and particularly incorporated on the movement side of things. So when you think about healthcare community partnerships, you can think about examples of cardiac rehab that do exist. You can even think about, in Alberta, for example, there's currently development of healthcare community partnerships towards cancer care. And there is some work happening related to neurorehab in this field. So this is Nancy Salbach's group again, a physical therapist and researcher from Ontario. She's the developer of the TIME model. And so this is a preprint, so it's just new work that she's working on right now. But our recommendation kind of alongside this work is that as we establish these partnerships and these models for neurorehab, we really need to think about incorporating kinesiologists deliberately into that link. And our hope is that by doing that, as I discussed before, you can ensure service quality in the community that goes beyond somebody who just has a 25 to 30 hour certification. And we provide opportunity for more individualized programming. And to sort of toot our own horn a little bit regarding individualized programming, this is an ongoing community program at the university and some research related to it that's currently under revision at the Journal of Aging and Physical Activity. So many of you know we have the Enriched Neurorehab program here at the U of R. It's a program that's run by kinesiologists and by student volunteers, students who are in kinesiology. And we provide individualized programming. So we're not just doing like a time or a fame program for a specific subset. We're working with any person with a stable neurological condition. And we're incorporating elements of exercise and task-oriented rehabilitation into it. You can see over here, this is just a small group of people who participated pre-COVID-19 pandemic. And if you see an open marker on the right-hand side, it means that the person made a clinically important gain in that assessment measure. So we see, if you look across all individuals, everybody made a clinically important gain in at least one domain of assessment. And our domains went across, upper extremity strength, functional leg strength, walking endurance, and balance. An important note relative to some of the prior reports of perceptions of a lack of expertise of fitness instructors for delivering these types of programs. We had no adverse events, still have not, and in interviews with participants, there was never any concerns with safety or expertise brought up. Like I said, we interviewed people and we saw lots of positive outcomes and suggestions. So to note a few themes that came up, and Dr. Tristan Hopper was very helpful in determining what these themes were. Is support through supervision was one of our main themes, and that's that it relates to that idea that people often get discharged to the community and essentially they're on their own. They're encouraged to be independent, and I think that that is important. But for most people with chronic neurological conditions, they still appreciate a level of support. And so you can see that reflected in this quote here, individual stating, it's not just like here you go and then you're on your own. The monitoring of it was a strength, and I think personally it was set up for me to have success. When we think about the individualized programming, again, you have these ideas of kind of creating programs that everybody, that you can deliver in sort of a single way. But individualized programming was considered to be very, very important. So here's a quote here. I was hoping to see a little bit more mobility in my hands, so I was given hand exercises and exercises for the legs and some balance things. So the program really touched on all of my needs. So we're not just working on gait and balance, we're working on whatever function that person would like to try to address. Another consideration, experiential learning, was a theme that emerged from talking with some of the volunteers who were involved in the program. So these are kinesiology students who are now getting experience in neurorehabilitation and hopefully being more prepared to go out into the world and deliver it. So we've got notes of it. Forced you to take hands-on. It forced you not to just have to put it on anyone else, but to just learn yourself, which I think is really, really great. And lastly, as you can imagine, we have quite a nice group up there. The social side of things is huge for people, having something to go to when their options are quite limited. And so here's an example of a quote again. It was such a warm feeling and such a feeling of encouragement from everybody. And it was just nice to be doing my own exercise program. So you can see the individualized bit there too. But at the same time, seeing other people who had circumstances that, that they needed exercise too. So I just loved it. And I think that also notes to the fact that we have people at different stages of recovery, different levels of function all coming together. And so still kind of related to this idea then of these new models of care that could incorporate kinesiologists into the delivery of this type of programming, we suggested this kind of referral model where somebody might self-refer or have a referral from another healthcare provider, meet up with a kinesiologist. They're screened for potential flags. Flags would be things like autonomic dysreflexia, spasticity, limiting range of motion, shoulder subluxation. There's a whole bunch of flags where we want to follow up with a physician, and then a kinesiologist could go ahead and start to make contributions. So going through the, as the kind of purpose of this is to start to initiate conversation very much to introduce the idea to therapists who are not comfortable or haven't previously used kinesiologists in this way. It is important for us to acknowledge some other considerations. For example, one reviewer suggested that the focus should instead be just on increasing patient access to regulated health professionals, that we shouldn't worry about involving KINs. Instead, we should just be increasing educational funding for PTs and OTs. For anybody who's done a KIN degree and goes into a PT-OT degree, the PT and OT departments need to get them through the program faster because they've already got lots of background, and that we need to improve reimbursement programs for PT-OT services. And while I think all of those would be fantastic things to do as well, and definitely need to be a part of what we do in the neurorehabilitation field, I think that the demand is so high and ever rising that we can do these things, and we can also start to incorporate kinesiologists and contribute that way. And so we've kind of made it through all of our sections here. I'm a little ahead of schedule, but not too bad. But I'll provide a quick conclusion. So, we started with this Mapping Connections report and just kind of hitting home the idea that there's lots of people, there's lots of Canadians living with mobility and movement challenges related to neurological conditions. And those people, even in that stage where they're out in the community living with these conditions, years after the onset, they can still make gains, but right now there's too many barriers for them to do so. So one way that we could start to break down some of these barriers potentially is by introducing KINs, carving out a piece for KINs in the mix. And then, of course, having better healthcare to community partnerships and formalized ones that involve kinesiologists. So really, I do think neuro-rehab needs you. And just wait, I think there is sort of a journey ahead here. So I think that getting KINs into neuro-rehab really is a bridge that needs to be crossed. There's going to be some heavy lifting along the way. You just got to grin and bear it. And I think it'll be worth it in the end. And if you caught on that I really just wanted to show some family summer vacation pictures, you're totally right. So just acknowledgements. Sue was a major contributor to the development of that particular paper that I focused on. So many people involved in the Enrich research and just the delivery of Enrich. Thank you. Lab members who contribute, and funding and partnership with the Saskatchewan Brain Injury Association. So thanks very much, everybody. I would love to hear questions or comments or thoughts on this topic.